All right, terrific. So for those of you who don't know me, I'm Bill Lavelle. I'm from upstate New York in Syracuse, and I kind of got the topic to talk about how we assess value. It's kind of like the complications talk, which is can at times be a bit dry, but hopefully we keep it lighthearted enough and entertaining enough that you garner something out of it. So as an overview, we're going to define some of the terms. So a lot of what goes into a talk like this is definitions. We're going to talk about how those definitions, particularly value and cost, differ depending upon who it is that is measuring them. In other words, whether what position as a stakeholder that you are. And we'll give one particular example of a advanced spinal technology that may be considered more at risk or of cost that may actually turn out to have a better long-term value for society and potentially for the patient. So Sig, I couldn't let a talk go without pulling a picture of you off the internet. I know this is actually an area that you've talked about to some degree and published on, and so if I get anything wrong, please chime in. So the difference between quality and value, while it is one of semantics, is one of importance. This reminds me of a discussion that I learned when I was a kid in school on accuracy and precision. So what are accuracy and precision? So accuracy is whether you get it right, whether you get the dart in the bullseye. What is precision? Precision is with your attempts, how close those attempts are clustered together. They mean two totally different things. You could be precisely inaccurate. You can be accurate and have very little precision and just be lucky to get it right one time. That is the difference between commenting on quality and value. So quality, as my friend Sig had commented on, I think this was from like Orthopedics Today, but it's the same definition that's published in numerous journals, is measured by a standardized process of care and a rate of compliance to that process. So let's set an example of that. So if your hospital has a quality measure of what day, post-op day your Foley comes out, that's a measure of quality. If you look at adherence to antibiotics, that's a measure of quality. Value can have a relationship with quality. The hope is taking the Foley out at post-op day one will lower your infection rates and perhaps lower your cost and increase the overall value. But value is measured basically by, as I talked at the beginning of this, by your position. So value can be measured by the patient, and we try to make surrogates to assess that as patient-based functional outcomes. Value can also be measured by another individual, such as you, the doctor. You may have great value in having great x-rays that show a wonderful scoliosis correction or great restoration with sagittal plane deformity, and it may be of value to you to not have complications. But at 2 years, what you may find is your patient may have numerous complications and still be happy, and your surgery may still be of value to your patient. So words are important. There's a term called a value proposition in healthcare, and it is analysis of the benefits of healthcare relative to costs. So where's the costs? So costs can be direct, and we're sitting in a room in an industry-sponsored event, and we know what costs are, right? So we know that pedicle screws cost an amount of money. We know that antibiotics and OR time costs an amount of money. But there's also indirect costs. We're doing surgery on people. And let's say we do a big surgery compared to a small surgery, and someone can't work for 3 months as compared to 2 weeks. That's a cost. That's a cost to the individual, and it's a cost to society. And so which costs are important and which ones are not is an element of substantial debate. It's a substantial debate to us as physicians. It's a substantial debate to society and to government. And so the hopes there is that time will gain consensus on what that is. Until then, we have debate, and what makes this an interesting area of conversation and really sets the stage for our discussions going throughout today's lectures to follow, learning about incremental values of technology. So a funny slide, but really sets the stage. Value and cost, it really depends upon your perspective. Is it a 6? Is it a 9? Are you happy to see the boat out in the ocean, or are you happy to see land because you're drowning and been stuck on a raft forever? So one of the measures that is important is to the individual. So this is me. You probably already figured that out. So to try to ascribe what a year's worth of life is, let's say that a guy like me who's 43 years old gets diagnosed with a debilitating condition, perhaps not necessarily a death sentence, but one that will make it such that I can't operate. I can't play with my kids. And someone offers me a cure, simple and easy, a pill. They're going to give me a pill. It costs $1 million for one pill. Does that sound like a lot of money? Yeah, it sounds like a lot of money, right? But let's say that pill has a chance of making me better, and if it truly does make me better for the rest of my life, all hopefully 40 years and beyond of it, if you do the math on that, that's $25,000 a year for a quality year of my life. Let's say it's a seizure disorder. Somebody gives me this pill that makes it such that my seizure disorder is gone. Is $25,000 per quality year of life a good number? And that's a question. And it may be surprising the answer to you, but if you look at data and you look at published results in our society in the US, it actually is. And you can debate what number is a good quality adjusted value for a year. In the United States, it's about $100,000, and that is also something that you can debate. There's also this other fun concept, which is called a utility score, where 0 is death and 1 is perfect health, and yes, you can have a 0 and wish you were dead. And how you ascribe that value is something called a gamble. You can assess that method by asking patients to really venture. What's it worth to you? So let's ask this little old lady who we were going to do our sagittal plane deformity surgery on, and says, well, ma'am, I know you can't walk and it's hard for you to get around, but would you be willing to have the surgery if I told you your chance of having a death incidence was 20%? Oh, no, no, no. What if I told you it was 4.6%? And so with that, you can make a utility score. And you can do it for a variety of different elements of complications and a variety of elements of different risk. You can ask patients the same thing. And the question is, which of these is important and which ones of these determines our utility to score? But a very important concept, one that's cited in all the literature that you look at on this topic. And it really does come to that element of simplicity. We do other surrogate markers to determine this. There are equivalents to this from functional quality of life measures. But this is really what it comes down to, is are you willing to risk something to have an improvement in your life? We as surgeons have a stake in this too. We have process-based measures that we look at, which are how good our x-rays are, what our disease-specific outcome tools look like, are important to our patients. But it is more than just a surgeon, both on the value end and on the cost end. So there are costs, like I cited, for the implants and the surgeries. There's also costs for the implants, the impact that happens to the patients and their families themselves. And we have to put them all together. This just shows an example of patient-reported quality of outcome measures. And these are surrogates to that utility score that I had shown you before. You can say, what is the equation that sets these equal? And I'll look at SIG and say this because I know you've reported on this. But if you look at papers that talk about this, there's a myriad of different ways that that equivalence gets drawn. A lot of them look at population adjustments, and they're actually different from country to country. So with regards to elements of confusion, so again, quality measures are things such as length of stay, surgical time, compliance with antibiotics. They can lead to value. They can demonstrate a decreased cost. They can demonstrate an increase in patient satisfaction and our process-based satisfaction, but they are not a direct measure of either value or cost. And they may be misleading. And so with regards to the stakeholder, it may be a meaningful thing to have a patient's time frame in the hospital be shorter. It may be a more meaningful thing to the patient to be in the hospital longer. I can tell you a scenario of what happens to me on a regular basis. I get someone who comes into me and they come in, they want their major spine surgery, and they come in with their family, and the family wants to know whether they're going to go to rehab. And why do they want to know whether they're going to go to rehab? Because while it may be more expensive to the system, to us, it's easier on their family. Nobody has to be home, take days off from work to take care of mom or grandmom for their particular surgery. So the question of cost is one that is very relative and one that's still an element of substantial debate. This is another term, a quality adjusted life year. It is a widely used number. It is specifically a number that looks at, like we cited before, a year in which your health is optimal. And that can be seen in a multitude of ways. This is actually a description that I I cited from an article that was written by Dan Resnick. So here's the example. 5 years in perfect health has a relative value of 1. 3 years with limited mobility may have a value to that patient or society of 0.85. And 2 years where you're substantially limited may have a value of 0.7. So what do you get in terms of quality adjusted life years for this particular patient in this particular disease state? It really is modifying or multiplying the number of years in that disease state based on that utility value that we talked about earlier. So for this patient, they have 8.95 adjusted life years that have been changed by whatever intervention that you have. This shows 2 different interventions described graphically that shows their utility. And that utility is also important because that utility can change over time, with a person having a worsened outcome as time goes on, and the value of that can be measured over time too. So let's say that you do an intervention that costs $1 million. And let's say that intervention only lasts a year. Probably not worth it. Let's say that intervention lasts 40 years. The economics of that intervention are much, much different. It is a topic that has garnered more and more attention. This is just a bar graph that shows the number of articles that has been specifically published, even up to the year 2011, of studies that look specifically at spine-related cost utility analysis. So an area that has garnered much, much more attention. So there's also another term. It's called an incremental cost effectiveness ratio, or an ICER. Again, a dry number, but at the end of the day, it is a figure that is used to compare 2 different interventions. So the cost of one intervention minus the cost of another intervention over the quality adjusted life years of one intervention minus the quality adjusted life years of a second intervention. It's shown graphically in the figure that is below the mathematical equation. This is another graphic description of change in value, or excuse me, change in utility versus change in cost. And it's a no-brainer. If you can do a procedure that costs less and has more utility, it is always advantageous, which is seen in the lower right-hand corner. If you can do an intervention that costs more and gains you very little in terms of utility, then that's probably not an intervention that you want to pursue. So let's say that we suddenly figure out a way to do spine surgery with a let's say a robot, and it perhaps adds very little to the improvement of patient's outcome, then that's probably a bad trade-off. Let's say that we do spine surgery with a robot and we have substantial trade-off. We have improved outcomes, shorter hospital stays, smaller incisions. Then that may be a substantially good intervention. And again, the quality adjusted life year value, or cost per quality adjusted life year value that we look at in the United States of America is $100,000. And some would argue maybe it should be less, but that's the number that we deal with today. So whose values are important as a stakeholder? These are 2 different patients that come in for surgery. Does it make a lot of sense to operate on somebody younger? Should we not operate on someone older if they don't have enough quality adjusted life years? And those are ethical questions that are important to us as a society. So let's look at one model very quickly before we delve into all of the interventions that perhaps may alter this ratio for us. This is an example that looks at anterior cervical discectomy and fusion with a plate, and anterior cervical fusions without a plate. And in particular, the procedure with a plate is associated with a cost of approximately $1,500 for the plate. From the player perspective, what's better? The cheaper procedure. From the patient perspective, what's better? So all the patients in this particular study who had a plate didn't have a collar. All the patients in this study who had a plate were able to ditch their collar early, and with that as a surrogate, they were allowed to drive, they were allowed to work. And so looking overall at the cost of their time, for the 3 weeks where they were asked to wear a collar, that value or that cost of the plate of $1,500 was more than accounted for simply by the fact that the patient couldn't drive and couldn't work. So a similar model can be said with regards to disc arthroplasty. Looking at disc arthroplasty compared to ACDF, this is an article out of the International Journal of Spine Surgery that looks at costs with regards to the implants, with regards to anesthesia fees, with regards to annual monitoring, and really based on the concerns about adjacent segment disease and surgery in the acute care setting. Patients with disc arthroplasty in this particular study were found to actually, while having an indirect cost with regards to lost productivity, having a more advantageous financial figure. This really just shows the same data with regards to costs over time. And so just to set the stage for this afternoon's discussion, this was a topic that was specifically looked at in the sport trials. It looked at degenerative spondylolisthesis and comparing costs for quality of life adjusted life here. That number for spondylolisthesis was found to be $115,000 at 2 years. And numerous elements of debate surround what that number should be. One particular element of debate that came to fruition was the costs when they were adjusted for true Medicare dollars raised that cost for quality adjusted life here substantially. And so, again, in conclusion, we talked about value and quality with respect to the stakeholder. And hopefully this sets the stage for our discussions of innovative technology, seeing their costs, seeing their potential relative value, and their importance to us as individual surgeons and to patients and to society. And thank you for your time. Hopefully that wasn't too dry.